राम राम सभी को. Dr. Rajendra Pandey. I think name is not new to the Augustus gathering. Acclaimed nephrologist, teacher at par, friend can be acclaimed. Dr. Pandey was the pillar to develop the nephrology department in the prestigious medical institution of our city, that is SSKM Hospital, popularly known as PG Hospital. He was there in the department as head till he retired from that place. From 2018 to 2021, he adore the post of Vice Chancellor of Medical University, Government of West Bengal. Dr. Pandey was always with us in this journey of IMA and UPONCON. So, with this short introduction, I request Dr. Pandey to start his deliberation of the day on medical ethics. Let us listen what is the wise word from the mouth of a wise man, Dr. Rajendra Pandey, sir.
Thank you, sir, for your kind words. Talking to you about ethics is like carrying coal to Newcastle. Probably this session could have been avoided, but it is now mandatory for getting the credit score. So we have to allot some time to it. Whatever I would be sharing is available on the website of NMC. It is last that it was compiled in 2002 and amended till 2016. Is there in these. Only 2 amendments has taken place after that in 22 and 23 that mainly goes for surrogacy and biological research, which I have tangentially touched upon. I would be not reading the slides, that is for you to read, because you can be able to read it faster than I can narrate. You can just go through the bold lines, which will suffice. You need not read the whole thing. Yes, we need to be regulated. And why we need to be regulated? Because aberrations are always there. Laws are made for menial people who are difficult to be controlled by administration. But higher in the society cannot be governed by those laws, and it is expected that they will conduct themselves in a manner which will go beyond the stipulations of the law. And that is what goes for the ethical standards. I will give you around 20-25 seconds to go through each slides. So each person, once he gets his registration, is given a copy of the Code of Medical Ethics, and it is expected that he will abide by the norms printed in it. So these are all evolved out of Hippocratic Oath, where we have always been taught to surrender our financial utility for favor of patients. I would personally differ from it, but ethical issues related to transaction need to be pure, and it should be pre-informed to the patient who is being cared for. And now in these 2 things, the core areas are the patient need to be respected, the confidentiality need to be maintained, except for information sharing for the communicable diseases, and not doing harm to any patients for lack of expertise in a particular domain. Now this is what is required for which we are here, but 400 delegates registered are not actually entitled to the credit score if they are missing this session. And we need to credit around 30 points over 5 years for a renewal of our registration. Now this is one important thing that people should know, that of course the indoor records are maintained by the institutions, but all in cases where disputes are there, probably a doctor should keep a record with him, go through each and line that he has mentioned. Even for your OPD patients, record needs to be made available to him within 72 hours of demand. And that is why probably EMR would be a better option for all of us for keeping such records. The one thing is that we often go for overwriting or not striking off the thing correctly. Please do not amend anything that you write on the line where it has been written. The amendments can always be done in a separate area, mentioning the specific areas where you need to be amended. Because in electronic records, everything will be there in the hard disk. So please do not delete anything, just add on with your amendments. This is what is required, and What is to be mentioned that some of us are quite fond of displaying our own picture on medical registration, along with medical registration in prescription pad. This is not considered as a proper conduct. Regarding, there has been a controversy a few days ahead regarding writing certain as suffix. So suffix in abbreviation can be written only for those things which are approved by National Medical Commission. Anything other than that cannot be added as suffix. But that very clearly says that you have a right to add anything that you want to your prescription pad if it is descriptive, not in suffix. Now, there are three things that your privileges to you, of which one is important, that you have a right to dispense medicine to your patients, charging them. But you should not be having a shop where you can dispense medicine to the prescription of other physicians. And you need to be careful when you are dispensing Schedule H and Schedule L drugs. They usually require the copy of prescription to be kept. If you are prescribing yourself, even your own prescription need to be kept if you are dispensing Schedule H and Schedule L drug. Regarding information to the authority about the communicable diseases, you need to inform them. Like, even if you are testing our patient for viral serology, we need to take an informed consent. I am telling them that yes, if you are positive for them, for the retrovirus, the information will be shared with the competent authority, and that need to be informed to them. Now coming to the core issues where we need our interaction to the patient, the responsibilities are very threadbare. What we perceive and what the law says are a bit different. Patients need to be treated not only with good intention. The importance lies also that he needs to be informed that what is available in the science, decision is to be shared, and the consequences thereof, which may not always be good, has to be informed to the patient. Now, regarding prognostication is one thing. Often in a need to glamorize ourselves, we often paint a rosy picture about the treatment. We need to desist from it. The clear information, the correct information need to be shared with the patients, which may dissuade him from pursuing the treatment. It may be a financial loss to the institution or to the doctor, but it should be shared very clearly. For obstetrician in general, when they are out of station, they have a right to give the patient to someone else who can take care of the patient in an emergency. But the responsibility of the person who is taking over the patient should end by the time the actual obstetrician or physician is available. This is one area where even we ourselves are not very comfortable when we are seeking consultation, because many a time people who are offering consultation are not following ethical practices. In an OPD consultation by a specialist, the best option should be that he gives a sealed suggestion to the physician concerned, who then may or may not execute whatever is given to him. And a separate counseling in absence of a physician in an inpatient consultation should better be avoided. Timing, we should respect the timing of the patients as well. Again, we talked about it, the prognostication. This is for consultancy. The prescription of the primary physician should never be overwritten. Suggestion only should be given which he has the right to accept or not to accept. We partly discussed about it. You can go through the bold lines. The last bold portion is important. We need to remember all the time. This also we touched upon. The responsibility should end as soon as the primary physician returns. There should be no tendency to carry over treating the patient, handed over patient. One should restrain when he is talking on public forums, social media or others, so far as enlightening with the medical informations are concerned. He should ensure that whatever is passed on is correct. We should not be engaging people who are not properly qualified for any assistance, and paramedical staff should be shared with all the learnings that we acquire through continuous medical education so that the better treatment can be offered. Now this part, I will go through with more precision, because a lot of controversies are coming up regarding this, and they are going to increase. Except for informing about your presence, absence, or availability, nothing can be advertised. If you are owning an institution, advertising for the institution and the facility available is all right, but individual doctor should not be promoted. This we talked about. No photograph on prescription. This we talked about, when you are not to dispense the medicine prescribed by other physician. This usually does not invite much attention, but it is propriety that we should not be engaging in too much of glamorizing ourselves. Confidentiality is an important issue. Name and other data on public forum should be shared only with prior permission, but if its identity is not disclosed, you can share the information for scientific purpose. Regarding sterilization, if it can occur because of any therapeutic procedure, both the couple should be informed about it. The last one is very important. ICMR guidelines are a different chapter, needs elaborate discussion. This is important even for government servants, that if you are not found on 2 occasions by inspecting team, they can recommend your name for deregistration. Now these are some of the penalties suggested in 2019 for penalizing people who are going for misconducts. They are similar, only the nature of aberration is different. Now those who are engaging in research, before going into it, please look into the details of information. Only I would suggest that sponsors should be very clearly discuss that the compensation clauses should be very clear. Any expenditure done by the participant in transportation and other losses should be compensated for, and if the results goes against the sponsor, the research outcome, and he is not willing to share with the sponsor after a certain period, you should be bold enough to share it with the fraternity and public if required. This is what has been conceived, perceived and emphasized for long. There are already 2 or 3 cases with NMC on which punishment has been awarded because of this. Now, every person people have filed complaint against has a right to hearing, which is a semi-judicial process done by NMC or state medical councils. And process of deregistration can always be challenged with the higher authority or even court. This is Geneva. Again, need not, because it is already available. Thank you. I'll take the questions if anything arising out of it.
Medicine from our chamber, it will be not taken as a shop. We are prescribed, selling our own prescription medications.
No, sir. How you dispense is your logistic requirement. The question is, you cannot prescribe the prescription of other doctors, one, and if you are prescribing Schedule H or Schedule L drug and that has been dispensed to the patient, in any form keep a record of it, because that can be misused.
But will we require GST for this?
GST?
Yes. Because now the common problem is coming, we can use the vaccination and patients are asking us to vaccinate in chamber, but then it will require GST.
So that is another issue that is coming with GST. I'm telling you, if you come to GST, if you are purchasing it and you are paying a GST for it. If you transfer the drug to the person at the same price, without an additional GST, you need not maintain any record. One. Secondly, if your turnover is less than 1 crore or by this in a year, you need not be part of the GST system. But if you are doing more than that, then obviously you have to keep a record for submission to the GST authority.
If you are administering vaccination at your clinic, patient is taking vaccination from outside, then if any complication occurs, side effect occurs, what will the implication? It is the responsibility to the doctors or those who are taking the vaccines from outside or?
True. If there are two components, one is administrative, one is medical. If you are administering a vaccine, you know there are certain known complications for which there are recommended observation period, and after that, if a patient is discharged and something occurs subsequently, it will be a shared responsibility always that patient can come back to you for treatment and taking care of the complication. The second is an administrative aspect where the administered material may be not of standard quality or a deviation which might have caused problem to the patient resulting in any amount of loss. That will be dealt separately. For the first component, if you are very confident that you have a standard practicing clinic where such problems can be taken care of, you can go ahead with it. But in case it is not, then vaccinate patient only in those areas where you feel comfortable of caring for the complications.
Yes, sir, Chairman. Thank you
Thank you, sir.
for taking us to the revision of our professional conduct, etiquette and ethics. But I have a question. In the present day, in the present scenario of AI and robotics, how is it going to change?
They are going to disrupt the medical practice, no doubt about. You have disrupted me by asking this question. Because at this point of time, perceiving how the legislation will take it is not clearer even to the judiciary. Artificial intelligence is supposed to assist in whatever you are doing. Like if you want to prepare slides, you can put it into the AI and they would give you, shuffle through them and they will give you in 10 to 15 minutes time. This favors you. The question comes when you start subserving the artificial intelligence, wherein information, whatever it brings, it's bringing from a repository. Now, if something is fed to the repository which is wrong, your analysis, interpretation and execution will be wrong. And you as a human being, a qualified human being, you will be responsible for it. Okay? So one need to be very careful in not believing anything that AI brings in. And the second aspect about robotic is simply, sir, has come into the medical field for precision. Because we know that when we are working in a smaller area, it is very likely that human vibration will probably may not be precise to incise or damage the area we want to damage. And that is why we are taking robotic helps. But the whole programming of the area and field of work is designated by the person who is controlling the robo. So he will always be responsible for the error executed by the robo. That is my interpretation, that is how judiciary is going to interpret it. But at the moment, by NMC or any other areas, there are no such guidelines that this is what is going to happen.
Thank you.